So I'm Robert Dubrow. I'm a professor of epidemiology and also faculty director of the Yale Center on Climate Change and Health at the Yale School of Public Health. Welcome to this session on climate action for health, what's stopping us, which I will be moderating. Of course, those of us working to increase climate action for health have encountered many barriers. On a macro level, these barriers include lack of political will, inadequate funding, and insufficient high-level strategic planning and coordination. But it's important to delve more deeply and with specificity into barriers to climate action for health. And that is what we will be doing during this session, which will cover implementation research, non-communicable diseases
to overcome this dark period
in disaster settings, resilient health facilities, action by health professionals, data and evidence, and multi-sector action. In the interest of time, I will do only a brief introduction for each panelist. If you have comments or questions, please put them in the chat and we will try to get to as many as we can after all the panelists have presented. So our first panelist is Dr. Revati Falke, who will speak about barriers to implementation research. Revati is the head of the Climate Change and Health Group of the UK Health Security Agency, formerly Public Health England. Her main interests lie at the intersection of climate impacts and the challenge of operationalizing resilience within health systems. Dr. Falke is a contributing author for the IPCC Sixth Assessment Report and lead chapter author for the UNFCCC Adaptation Gap Report. Dr. Falke.
Thank you, Robert, for that kind introduction, and morning, afternoon, everybody. I am going to try in the next 7 minutes to outline some of the challenges and the barriers that we face for scaling up ambitious implementation research for climate change and health, and also kind of end with the thought of how we can address these inequalities. So next slide, please. I think the main challenge that we are facing in our current understanding of how risks are distributed and what is actually being done in terms of responses on the ground is the evidence inequity. And I think although the amount of research that has gone into understanding climate risks for health and the other way around has increased exponentially in the last couple of years, there are still significant gaps in high impact areas in the world. And if you see also that in terms of the distribution of the topics that are covered, there are some topics that are still neglected. And one of them, which is close to my heart, is of course the health systems resilience and how health systems are preparing and responding to the climate change and environmental challenges that we face today. Next slide, please. I think the first thing we, all researchers and practitioners should be thinking about is to move away from what is feasible now versus what is actually needed. And I think that majority of our work, of course, speaks to, and of course, without proper and I'm speaking from a public health researcher's perspective, and I'm sure that colleagues from the environmental sciences and the climate sciences will have their own views on this. But I think the first thing is that we do, and this is my personal view, is that we do lack to some extent the level of ambition for implementation research for health, public health, and climate change. And the other thing is that, yes, we do talk a lot about co-implementation, co-design of research, but to a very large extent, we still see practitioners and policymakers as consumers of our research, as somebody who are uptaking or the end product is of value for them. And I think that there is a movement in bringing them back to the table, to the conceptualization phase, where they are part of almost commissioning what is it that they need to know, when is it that they need to know, and then is the research community kind of catering to the needs of the people who are making the decisions on the ground. And yes, nationally, these things are important, but more important from a adaptation point of view, it's about doing this at the local level, risk assessments and responses both. Of course, needless to say, financial barriers are there, but there are also barriers of data infrastructure. In many high impact countries, we still don't have the longitudinal data sets, the time series data sets that climate scientists would need, particularly for health, and also the data resolution. The majority of the impacts need to have a high resolution data, and we still don't have access to. So what kind of systems can we put in place so that we can have that data at hand when it is needed? Needless to again say, the recognition of urgency. So we have been a bit slow. Climate change necessarily requires us to repurpose some of the methods from other fields, because of course the interdisciplinary science and the wide interconnectedness of health and climate change both. And we necessarily need to scale up the repurposing of existing methods in other fields that need to be brought into public health to look at how we can do that. Knowledge mobilization as well, that yes, a lot of knowledge is generated, but not necessarily mobilized to the people who need it in a time that they need it. So that is another barrier that we need to do. In the last couple of years, things have improved, but we still overtly focus on understanding risks. And I'm not saying we don't need to do that. We need to do that on a continual basis, but we need to match that ambition with how the responses are being done, and what can we learn from those examples. Publication bias, definitely, that we have more often published successful case studies. And I think what we really need to do is to balance that with also bringing around evidence of what has not worked. Because only when we have the complete picture of what works and what doesn't work, we will be in a better position to prioritize the implementation work that we need to do. And of course, we need to have a united voice for scaling up financial support for implementation research in science. And I'll end with the last thought. Next slide, please. I'll end with the last thought, which says that there is a lot of problem with this phrase of what gets measured gets done. And I would like to have another phrase, which is also problematic, but different from this one, which would say that, you know, what is being currently done needs to be measured. And that needs to be shared out so that people can learn from the mistakes as well, because they're as valuable as successes. Thank you.
Okay, thank you, Revati, for a very nice and concise talk. Okay, so our next speaker is Dr. Saria Hassan. She will speak on barriers to the protection of people living with non-communicable diseases during and after hurricanes. Dr. Hassan is Assistant Professor, Department of Medicine, Emory University School of Medicine, and Hubert Department of Global Health, Rollins School of Public Health. Dr. Hassan is an internal medicine and pediatrics physician with a research interest in applying implementation science tools to address the needs of people living with chronic disease in humanitarian settings. She has worked in the Caribbean for the past 5 years. Dr. Hassan.
Thank you so much, Rob, for that introduction. So what I hope to do in the next 7 minutes is really build on that framework and challenge that Revati has given us to really use the framework of implementation science to think about how we can do better at addressing a very important gap. And that is addressing the health of people living with chronic disease during and after disasters. And so let me first kind of just set the stage with some definitions. I refer to NCDs, or non-communicable diseases, and those include diabetes, heart disease, lung disorders, cancer, and mental health. I'll also talk about extreme weather events, and the most recent IPCC report that lists the ones that you see here as extreme weather events. but I'll be focusing primarily on storms, including both tropical and non-tropical cyclones. And I do that because in the last 5 years, we have seen significant devastation all around the world. Again, as Robin mentioned, I focus on the Caribbean, and 2017 hurricanes Irma and Maria, the complete and total devastation and destruction we saw in the Caribbean. We saw it again in 2019 with Hurricane Dorian in the Bahamas, where a Category 5 hurricane lingered for over 48 hours over the islands of the Bahamas. But it's not specific to the Caribbean, as many of you here know. Cyclone Idai in Mozambique, the severe floods we just recently saw in Kerala State in India. But what we're starting to understand is what is the morbidity and mortality beyond the destruction that you see in these images. What is the morbidity and mortality that we're seeing after these events, and what are their causes? And we started to spend a lot of time and focus from a research perspective understanding this after hurricanes Irma and Maria. And this is data from the United States, which showed that almost 90% of the deaths that we saw after Irma and Maria were indirectly hurricane related. And 35% of those were due to exacerbations of existing medical conditions. So what does this translate to? A lot of attention, and there was a lot of controversy around the mortality that we saw on the island of Puerto Rico after Hurricane Irma and Maria. But what we clearly saw is that there was a significant increase in the excess deaths due to Hurricane Maria in 2017 compared to the historical averages during that day. And further research has focused on what the cause of that excess mortality was, and clearly pointing to the NCDs, the non-communicable diseases, being led by an increased excess death due to heart disease. And so that brings us really to today, where we're trying to learn more about how these extreme weather events worsen NCD-related outcomes. And what does that mean to the world, not only just the Caribbean region? And there are several mechanisms that we know lead to this: extreme weather events worsening NCD-related health outcomes, limiting access to healthcare, worsening mental health, and what that does to NCDs, and causing displacement and migration with limited access to healthcare. A disclaimer that all of these citations you see here are data from high-income countries. And so what does this mean, though, for low and middle-income countries? Well, the IPCC report clearly showed us that what we're going to see in the future as a result of climate change is an increase in the amount of precipitation we see as a result of tropical cyclones all over the world, again, not just in the region I'm working in, that we're gonna see an increase in the strength of these events, again, including these low and middle income country regions you see highlighted in the middle figure. And then perhaps a change in the wind speed as well from non-tropical cyclones. But what we also know is that there's been a significant rise in NCDs among the most vulnerable, with the most recent WHO data showing that at least 75% of mortality due to chronic disease occurs in low and middle income countries. This is data from the Global Burden of Disease study. The top one shows 1994. Blue is disability adjusted life years due to chronic disease. Pink, disability adjusted life years due to infectious disease. You compare 1994 in the top to 2019 in the bottom, you clearly see this epidemiologic transition from an increasing cause of mortality, or in this case, disability adjusted life years, due to chronic disease. So what is this gonna mean? Well, what this means is that I'm kind of positing that we're gonna have a new double burden of disease for LMICs. The increase in NCDs combined with the increase of severe weather events that the new IPCC report showed us. But LMICs have weaker health systems and greater vulnerability for a number of reasons. And this is therefore going to cause worsening global health disparities. What can we do about this? How can we do better at understanding, again, responding to Revati's call, understanding what the challenges are to managing chronic disease during disasters? The scoping review that we did in Health Affairs highlighted some of those, as the disrupted healthcare systems, communication challenges, mental health challenges, the access to clean water, and the access to healthy food. And it proposed some solutions, that we needed better surveillance systems, better chronic disease self-management, more access to medication and healthcare service points, but importantly, again, in response to what Revati was saying, a need for evidence to inform the integration of NCDs into disaster preparedness and response. And this disaster preparedness and response can occur at multiple levels, as we know, from the individual to the regional level. And so we've now started a collaboration with many of the organizations you see listed here to understand what we can do better to address that challenge of people living with chronic disease and disaster. The challenges and primarily that lack of integration between NCD and disaster divisions, but also the opportunity of today. And for what COVID has brought us, one thing it has is this opportunity to collaborate at a regional level. How can we leverage that now to address regional response to people living with chronic disease? And really this focus on NCDs and the Build Back Better movement, leveraging that again to show us how we can do better at integrating NCDs in disaster. And so I propose to you a way forward, acknowledging the urgency of now, and that's primarily why most of you are here today, acknowledging this new double burden of NCDs and disasters that will worsen both in-country and between-country health disparities. We need to leverage this moment, COVID-19 opportunities giving us an ability to focus on NCDs and regional collaboration. But we need to develop and test strategies for how to integrate NCD management and disaster preparedness at all levels. We need to build and improve upon NCD surveillance systems, build those resilient health systems that you're going to hear about more in a minute. And we need the evidence. There's really a role for implementation research in this area to generate generalizable knowledge on the approaches to address the needs of people living with NCDs in disasters that can be adapted to different contexts. Thank you.
Thank you, Saria, for a wonderful talk. Okay, so our next speaker is Major Clemens Buter, and he's going to talk about scaling up resilient and green health facilities. Clemens is the lead planning and operations advisor in the Health Emergencies Department of PAHO. Specifically, he serves as lead planning and operations advisor for the implementation of the Smart Hospitals Initiative in the Caribbean. In addition, as a member of PAHO's Regional Health Response Team for Emergencies, he has contributed to disaster response efforts, including those for Hurricanes Irma, Maria, and Dorian. Major Buter.
Thank you, Robert, for that kind introduction, and good morning to you all. And also thanks for the opportunity to present you the Smart Healthcare Facility in the Caribbean project during the next 7 minutes. I think this is a great practical example of what can be done in the area of climate sustainable and resilient systems. An example is the healthcare facility, the Baroli Health Center in St. Vincent. Later on in my slides, I will show you the before picture as well. The project is funded by the UK Foreign Commonwealth and Development Office in the amount of £46.3 million, implemented by the Pan American Health Organization, of course in very close collaboration with the Ministries of Health. The Caribbean is hit by natural disasters every year, and in the event of an emergency, health facilities to treat the sick and injured are vital. Over 2/3 of hospitals in areas of higher risk of disaster and health services are frequently disrupted following storm, hurricane, earthquakes, heat waves. We recently had the volcano eruption in St. Vincent, and on top of that, of course, we have the current pandemic, and climate change will further increase this level of risk in the Caribbean. More than 67% of hospitals in Latin America and the Caribbean are in areas at higher risk for natural disasters and climate change. At the same time, hospitals represent almost 70% of the Ministries of Health national budget. In the Americas, 61% of the impact on health facilities is caused by earthquakes, 17% by hurricanes, 14% by floods, and 8% by health emergencies. These numbers are even outside the current pandemic. But it left millions of people without proper health care and resulted in billions of dollars of direct cost. In phase 1 of the Smart Hospital project in 2013, 2 demonstration retrofit projects were done. One at the Georgetown Hospital in St. Vincent, which was an older facility, and the second at Poxon Hospital in St. Kitts, which was newer, both of which proved to be successful. The retrofitting works included replacing the windows to meet higher design wind speeds for this region, strengthening of the roof to accommodate solar panels and ashfall in St. Vincent, improving the natural lighting and ventilation, and improving the fire safety and emergency egress of the facilities. 10 months after the completion of Georgetown Smart Hospital, the energy data was reviewed and there was an estimated 58% reduction in electrical consumption. Similar checks were done at the Boxen Hospital in St. Kitts, and that facility saw a 50% reduction in the electricity bills. So it's not only climate change adaptation, but also mitigation. Phase 2 of the smart healthcare facilities in the Caribbean project started in June 2015 and is still ongoing as we speak until the end of December 2022 in 7 countries: Dominica, Grenada, St. Lucia, St. Vincent and the Grenadines, Belize, Jamaica, and Guyana. And what we are trying to achieve is really to enhance safety standards, to reduce the downtime and damage to hospitals from natural hazards. And I think the 2 facilities in St. Vincent recently showed that after the eruption of the volcano. Lower operating expenditure due to water and electricity consumption savings. Later on in my presentation, I will say something more about this because this is one of the things that is challenging us as well. And national and regional capacity building to apply smart standards. So what is a smart facility? It's both safe and from natural hazards, and it's green. There are several win-win ways to accomplish this, which in the process can be cost-effective, cause a reduction in greenhouse gas emissions, achieve climate change adaptation measures, risk reduction, and development benefits. The image shown in the presentation defines what is meant by smart. It illustrates that improvement in safety, or an A score on the Hospital Safety Index, results in a safe facility. A score of more than 70% in the green checklist equals a green facility. The graphic presents safe and green factors to consider, and where and when these are combined, help to create a sustainable smart facility. Other measures, such as use of eco-friendly flooring, paints, furniture, and furnishes, will further contribute to the increased sustainability and risk reduction. Health facilities can also improve their smartness by greening their operations. This includes using less paper, recycling, generating less and properly disposing of waste, solid and otherwise, proper disposal of pharmaceuticals, using environmental benign chemicals, and using more local sustainable produced food. So please allow me in the final few slides to give you some examples of what we have been doing. We basically have 3 outputs. Output 1 is assessments and training. Output 3 is specifically PR. Of course, you can find us on the internet, and we're on social media as well. But more importantly, we trained over 400 people in applying the Hospital Safety Index and Green Checklist. And this database that was generated, over 400 healthcare facilities were assessed. We actually trained over 1,000 people doing these assessments. And these 400 facilities, we have the data now available. The Ministry of Health have the data available. And that is very important to guide future decision-making and also to attract other donors. We put a lot of effort. One of the challenges in the Caribbean is, of course, maintenance. So we developed a preventative maintenance manual for healthcare facilities, and we provided many courses to maintenance staff and health staff. The importance of contingency plans, to rehearse these plans, to check these plans, to do simulation exercises. And finally, what we worked on as well is while patients, occupants, health staff, members of the community, when they're waiting in the waiting area anyway, it's a good moment to show them videos, show them posters, flyers, to teach them as well what they themselves can do at their own homes. For a simple example is, for example, the installation of LED lights. So the aim is to finish at the end of the project by December 22, 55 healthcare facilities. There's many more in the Caribbean. I heard a number of about 650. We've done over 400 assessments, so there's many more to do. And we're going to deliver 6 full designs to the Ministry of Health. By the end of this year, we should have 40 facilities done. And as I promised, this is the before picture of the Barouly Health Center in St. Vincent. Some challenges, of course, with COVID-19, the travel restriction, which is also a challenge for quality assurance. So we can't always send our inspection teams to check what's going on. I think very important building codes and standards. Sometimes they are there, but we need to make sure that the people and the countries are using those codes and standards as well. In our project, we work with design and inspection firms. We have technical consultants, but on top of that, we have the check consultants, which are really important for review, second opinion in the area of structural, mechanical, electrical, and plumbing, and even quantity surveyors is essential to the success of the project. Two things I would like to highlight. We always worked on a saving maintenance mechanism. So the savings we generate by installing solar panels, we want to use those savings for maintenance. The problem is that the bill of the utility bill is actually paid by the Ministry of Finance from a consolidated fund. So we're looking at ways and discuss not only with the Ministry of Health, but also with the Ministry of Finance to make sure these facilities have their own budget and there is an incentive when they see that they saved money and that money can be used in their own facility. Another thing is the utility companies' policies. For example, when I are forced to deliver my electricity from PV panels to the grid, and they pay me back 25 cents. And when I use electricity from the grid, I still need to pay about $1, which these amounts are different in every country, but obviously is not something we desire and needs high level commitment and discussion. Just to finish, very happy to see that, yeah, from smart concept, we became a smart movement in the region. We see increased engagement of national partners. We see a lot of interest from other donors, so not only our own donor, FCDO, but also, for example, the EU in BVI, in Belize, in Sint Maarten. BVI is using the concept even for the new courthouse. They're using it for their schools. We are working with the EU in Sint Maarten. We do not only do retrofitting, but we do 2 new shelters in Sint Maarten. We have a lot of interest from the private sector who really want to adapt as well. So we really see increased capacity building. And this is what I would like to present. Thank you very much for the opportunity, and back to Robert.
Yeah, thank you, Clemens. Very important work. All right, so the next speaker is Dr. John Kocher, who's going to talk about barriers to action by health professionals. John is a research assistant professor at the Center for Climate Change Communication, George Mason University. His work focuses on identifying ways to effectively communicate about the health implications of climate change and air pollution, and developing strategies to help a wide range of organizations more effectively activate and empower citizens to shape society's response to climate change. John.
Sorry about that, I was still muted. And now I can't control my slides. There we go. Thanks for that introduction, Rob. So I'll be talking today a little bit about a survey of health professionals that we conducted in the fall of 2020. These were mostly general adult medicine physicians spread across 12 different health professional societies in a variety of different regions around the world. So when we talk about engaging health professionals on this issue, I think ultimately what we want to aim for is having more health professionals helping various decision makers improve their decisions, make more informed decisions about how to mitigate and adapt to climate change, whether it's government entities, civil society, industry, or even just individuals. And this can, of course, take place in terms of decarbonizing health systems, as Clemens talked about, or it could entail health professionals speaking directly to their patients about climate change, or health professionals might work through a variety of some of these intermediary organizations to influence government decision makers. So when we looked at how prepared health professionals are to take these sorts of actions, one of the things that we wanted to look at was whether they in fact already see climate change as an important health issue. And so what we found is that for a variety of specific health impacts, a majority of the participants in our survey already thought that climate change was making those health problems worse. And then a third to nearly half thought that climate change was already making a variety of other health impacts worse. But when we asked them whether each of these impacts would get worse over the next 10 years if nothing was done to address climate change, majorities of our respondents thought that all of these impacts would get worse. So the take-home message here is that many health professionals already feel that the impacts of climate change are already adversely affecting health in their country, and that it's only going to get worse if nothing else is done. When we ask them whether they feel that health professionals have a responsibility to bring the effects of climate change to the attention of policymakers and the public, we found that large majorities of participants felt that they had a personal responsibility to do this. And this is important because in other research, we found this to be a strong predictor of whether or not health professionals will actually take action. But as we know from many years of social science research, even when individuals perceive a threat as relevant to them and feel a responsibility to take action to address that threat, a variety of barriers can prevent them from taking action. And so what we found, perhaps not surprisingly, was that the most frequently cited barrier for health professionals to doing more public communication about climate change and health was a perceived lack of time, that they just don't have enough time to do this. Another 41% said that it was a lack of knowledge that was stopping them from doing more public communication about it. About nearly 1 out of 3 said that they thought it wouldn't make a difference if they did so. And then smaller proportions of respondents also cited a lack of support from their peers, perception that the topic is too controversial, or that it's too risky for them professionally or personally. When we asked them what resources might be helpful to them, we found that majorities of the respondents felt that continuing professional education on climate change and health would be useful, guidance on how to make their workplace more sustainable, like Clemens talked about. They were interested in action alerts on how and when to advocate with policymakers about climate change and health, as well as more training on how to communicate effectively about it. Finally, a majority were also interested in additional patient education materials on the issue. So just briefly to sort of talk about how to address some of these things. In terms of the time constraints, right now it's not entirely clear to what extent this is a perceptual barrier versus a real barrier. It's probably some combination of the two. And so right now, I think it would be good to try and figure out whether there are interventions that could be provided that could sort of calibrate health professionals' perceptions of the actual time required for some of these actions. So for example, it may only take a few minutes to actually send a letter to one's elected official. And so one potential solution that's been proposed is providing people with a menu of different actions with actual estimated time required for each of those actions, so that they can see that perhaps it's not as much, it doesn't require as much time as they originally thought. But I think it's also critical here to develop programs that really incentivize health professionals to do these sorts of actions, so that they're actually rewarded for these sorts of efforts. In terms of lack of knowledge, clearly there's a demand for more continuing education and medical education about this issue. And I want to stress that it's not just about helping them better understand the impacts of climate change, but also the benefits of solutions to climate change. So in some of my other communication research, we found that talking about health solutions to climate change is potentially even more important in terms of raising people's awareness and concern about the health effects of climate change, more so than talking about the impacts. But really, it's the combination of these two things together that is optimal. And then also just to underscore that continuing education should involve not just information about those two things, but also training health professionals on how to communicate clearly about this to a variety of different audiences. So obviously talking to one's patients is going to be very different than, for example, testifying before government leaders. And then finally, how to address the lack of efficacy, the perception that it wouldn't make a difference if they took these actions. So one way to do this would be to use role models who have actually had successful experiences and have a track record of making an impact by taking these sorts of actions. And it may be in climate change and health, or it may be from other health-related problems, right? And so using those prior examples to show how health professionals can make a difference could be useful, and we need to do more research to figure out how best to formulate those sorts of interventions. So I'll go ahead and stop there. I'll just let you know that the study that I talked about today was published in Lancet Planetary Health, and this was a collaboration with the World Health Organization, the Global Climate and Health Alliance, as well as the World Medical Association. Thank you.
Thanks, John. Very nice work. Okay, our next speaker is Dr. Georgiana Gordon-Strawn, who will talk about integrating multi-sector data and evidence for action. She's director of the Tropical Metabolism Research Unit of the Caribbean Institute for Health Research at the University of the West Indies. Georgiana specializes in epidemiology, health policy, health services research, research methods, and biostatistics. She's a member of the Essential National Health Research Committee, Jamaica, which has now developed a national research agenda and is working on a national health research policy as a part of Jamaica's Vision 2030 strategy. Georgiana.
Thank you for that lovely introduction, Robert, and good day to all joining. So I'm going to be looking at integrating multi-sector data and evidence for climate action in the Caribbean. What's stopping us? So I'll start by just looking at the lay of the land, and in looking at the lay of the land, I will just look at data governance in terms of the laws that exist within the Caribbean. So I'm happy to report that all Caribbean countries have a Statistics Act, and that there are 15 Caribbean countries with data privacy laws, Jamaica being the most recent of these countries, Bahamas being the first to start and to enact their data protection and data privacy law. So we can start by saying that the legal framework exists for the protection of personal data and the integration of data for the provision of national statistics. We can't talk about data without looking at the ICT infrastructure. And in the Caribbean, all countries have comprehensive ICT infrastructure for business processes. If we look specifically at health data, what we will find is a mix of sources and ways of collecting and archiving data. These include purely electronic database systems, and some are hybrid systems, which are some of it is paper-based and the rest is electronic. Now, an unfortunate thing is that our patient medical records are mostly paper-based. As you all know, health is not just the freedom from disease, it also includes environmental and social determinants. Within the Caribbean, these data are collected by several different agencies, and so it can present as a fragmented type of ICT infrastructure. On the weather and climate side, our meteorology and hydrology data are all electronic, and this is in part due to the Caribbean Institute for Meteorology and Hydrology and also the country meteorological offices. So we all know that if we're going to be integrating this system of data, we will have to look at the basic components. And the basic components, everybody knows, would be health and climate change. From the health perspective, the sources that we have are varied. So we have clinical sources in terms of disease data, we have environmental data, there's agriculture, there's data from planning agencies, and the list goes on and on. For climate and weather, we have meteorological data for most of our countries, but we also use some remote sensing sources, such as NOAA's satellite, for getting our weather data. We're obviously not just satisfied in getting real-time data. We also want to be able to project our weather data to build climate models using different scenarios and using predictive mathematical models. And we have been doing this. We've also downscaled our data so that our projections can be more specific to our vulnerable areas and our vulnerable communities. There are several projects going in the Caribbean which are trying to build climate resilience. And I'm just going to mention this one because its first objective and primary objective is to improve regional processes to acquire, store, analyze, and disseminate relevant climate data. And under the Caribbean regional track of the pilot program for climate resilience, funded by the Climate Investment Fund, implemented by the Inter-American Development Bank and the University of the West Indies, we have been able to improve our LIDAR data, which would be our bathymetry and topography data. So it's all good on the climate front. So what's stopping us? In our situation, where data exist, the integration of the two basic components requires the sharing of data across agencies. And not just the sharing of the data, but the synthesis of these data into reports on useful indicators. Now, it may seem simple, why not just draft up some data sharing agreements across these agencies? But our experience has shown that this is not as simple as it appears. There's also an issue of trust in handing over data and the misuse of data. So mechanisms for integrating data of different types and architecture is also necessary. Improving and maintaining our ICT infrastructure where data exists is also quite necessary. But where we do not have data, it gives us a great opportunity to decide on which indicators matter to us from a climate and health perspective, and to build the systems and mechanisms for collecting these data and for testing these interventions for integrating systems. Now, what we're doing is not new. The Lancet Commission has been reporting on indicators for climate and health since 2015 and launched their 2021 report in October. So as we look towards the future and look towards the horizon, we see that we have several opportunities, and I'm only highlighting 3 in the interest of time. So the launching of the Lancet Countdown, regional center for small island developing states for tracking the progress of health and climate change is an excellent opportunity. And this will help us to build on existing frameworks for integrating multi-sectoral data for tracking the impact of climate change and health in SIDS like the Caribbean. The University of the West Indies is hoping and has secured some funding for the development of a climate health observatory for the Caribbean. And this will start first with one country and then will be built out. It is also good to note that efforts towards data digitization have increased, and this is now a major component of funding for several of the multi-development banks and agencies who have recognized this as an important effort. So I will close with 2 points. The first is that it's very important to integrate multi-sectoral data for climate and health. And we all know why, so I don't think it's necessary to reiterate that. But after sharing this data, there is still a lot of work to be done to understand the outputs and to understand how to use the results for climate action for health. Thank you.
Thanks, Georgiana, for that great talk. Our final speaker is Dr. James Hospitalis, who will talk about joining up the silos for climate action in health. James is the founder and CEO of Earth Medic and Earth Nurse Foundation for Planetary Health. He founded Earth Medic and Earth Nurse to mobilize health professionals and others to address the climate and health crisis. He chairs the Defeat NCD Partnership Executive Committee, addressing NCDs, non-communicable diseases, in low-resource countries. He also was inaugural executive director of the Caribbean Public Health Agency. James.
Thank you very much, Rob. Good morning to everybody who's joining us. I hope you can see my screen. So I will be talking about joining up the people in the silos. A point I make that it's not the silos that cooperate, it's people in silos that cooperate. And we really need to do more of that to be able to act at the speed and scale that we need in climate action. Now, if you look at the policies and plans to address development challenges, such as climate change, they typically contain phrases such as multi-sector collaboration and public-private partnerships. But is this just rhetoric? In our conference on climate change and health last month in the small island states, we heard the need to join up the silos every day, every session. But as one former minister told us in the conference, people are not wired for collaboration. Around a cabinet table, each minister is thinking of his or her needs. In public-private partnerships, the private sector values time and money differently from the public sector and academia, which can lead to misunderstanding and breakdowns in collaboration. Often there are constitutional or legal barriers. I heard that in a One UN, One Ocean webinar in the COP a couple of days ago. The language of one sector may be very threatening to another sector, and so on. And so joining up people in the silos has many levels, and it's been touched on in several of the previous presentations, including Georgiana, who just spoke. First, within the health sector, more collaboration is needed between hospital and primary care, between public health authorities, and between practitioners who are operating in the private sector. In Trinidad and Tobago, there are hundreds of private GPs. So Clemens, I think your greening system can work very well there. Second, between health and other key sectors, environment, planning, agriculture and food. Saria made the point of the importance of health linking up better with disaster and emergency management systems, transportation, media and communications to reach people, academia, South-South-North collaborations. I would note that there are some industries and sectors where you have fundamental conflict of interest from a climate and health point of view, such as the tobacco industry and fossil fuels. If we think of the climate and health movements, and if you do a Google search on climate and health, there are many organizations, initiatives, partnerships, and alliances, only some of which are shown on this slide. Most of these alliances are based in the global north. There is no single go-to organization for doctors and nurses. So the question I ask as a physician is, are we like a heart in atrial fibrillation, with a lot of muscles contracting and nerves firing, but with no effective cardiac output? How do we establish more sinus rhythm? Do we need a climate and health leaders meetup for better collective impact and action. Now, what works in joining up the people in the silos? This is an area that's really ripe for research. In a recent UN meeting, I heard one person from FAO said, money works because if you put money on the table, if the Green Climate Fund and others specify that people need to work together, it's a big help. Having one overall idea or compelling vision is another way to try and join people up. And I think that climate change increasingly will become an alarm bell that hopefully will pull people together. Joint meetings and joint sessions for planning and for working together. Mandates from the Dominican Republic in our conference last month. We heard the representative say that mandates work very well if the government says, you need to work together. Georgiana was talking to me that going to the other sectors with health arguments and showing the data that health is touching everything is one way also of bringing people together. Reframing. I worked for years trying to get attention to the problem of diarrheal disease in the travel industry. They used to call me Dr. Diarrhea. But when I reframed to talk about improving profitability through attention to health and hygiene, I suddenly had a much more receptive audience. Training is needed in climate matters, in health diplomacy, and specifically in negotiation and partnership. What are the skills that we need in the health sector to be able to work more effectively with others? Maybe we need some aggregators. I recently came across climatesavers.com, which is about how do you decelerate the climate crisis by accelerating collaboration. This slide focuses on something that I found useful in my own efforts to build alliances and partnerships. It's interest-based negotiation training, such as that based on the books of Roger Fisher, Getting to Yes and Getting Past No. The stick man on the left is my summary of an easy to remember diagram of 7 key points in any kind of negotiation or partnership building. And the 2 at the top, relationship and communication, are really key. I call them the keys to the circle of power, to really understand people's interests and come up with, explore options that could be win-win for different parties. And it's more difficult in the remote world of that we now have to inhabit, virtual meetings, Zoom meetings, to build relationships and communication. A lot of communication is nonverbal. So how do you do that in a virtual way is a different kind of challenge. And you see at the bottom some publications that have looked at if negotiation improves performance, and a website that in Cambridge, Massachusetts, that does a lot of this training for the UN and WHO system. Building on the negotiation skills training is partnership building skills. This cartoon attempts to put some perspective on different complex challenges. Everybody is consumed by COVID, but the economic recession is contingent on that, is a big problem that's coming along. And as most people on this webinar should know, climate change is going to be a much bigger problem than COVID is per se. The Partnership Initiative, based in the UK, is one group that specializes in partnership skills training for multi-sector action, and also works with a number of UN and WHO partnerships. So I hope in this talk I've given you a few ideas for how to join up people in the silos, as that's a common symptom or common complaint in all these sorts of sessions on how to achieve better collective action. Thank you very much.
Thanks, James, for really pulling things together there. I think a common theme across many of the talks was the need for partnerships, the need to work together. Another common theme was, or a barrier that we're facing is the need for evidence. So we have about 5 minutes left. So let me open it up to the panel. Maybe, and participants should feel free to put questions or comments into the chat. But let me actually start by asking Saria in terms of, you identified the barrier of lack of integration between disaster management and people working on NCD control. How do you see ways to try to overcome that barrier?
Yes, absolutely. And I think it's already starting. And that's probably what's most exciting. Organizations that are primarily responsible for disaster preparedness and response in the Caribbean have started to train their own disaster response individuals on mental health management, for example. So SEDEMA has done a lot in training their response providers on mental health. Similarly, the World Diabetes Foundation has funded training to integrate disaster and NCD preparedness course, so that now people who are interested in being responders can actually have training on NCDs. So the conversation started, and what we now need to do is to evaluate these interventions so we're able to scale them up and scale them out.
Great, thanks. I think, okay, so actually I'm seeing a question come up, so maybe let's see. Okay, it's question, can you speak to the role politics, special interest influences, and disinformation, misinformation can influence regressive no action on climate and health? Are there ways in which political gridlock denialism can be overcome? Wow, that's the big question. So let me open it up to the panel.
That is a big question, Rob, and we live in a world where disinformation and misinformation spread faster than the virus can spread. And some folks live in one echo chamber and other folks live in a different echo chamber. And how to get around that, one climate scientist that I've seen, Catherine Hayhoe, has published a really nice book called Saving Us that focuses on identifying not the differences, but what are the common values we share with others, and build a relationship with them around those values. And then perhaps you have a better chance of having a discussion that's productive rather than one where we're just fighting each other. I think I don't have the complete answer to this. There will be more pandemics to come. And so we actually need to be better prepared for the waves of information, misinformation and disinformation that are likely in the future.
Yeah, thanks, James. John, I don't want to put you on the spot, but as a communications person, do you have thoughts about this?
Yeah, so I really can only speak to the US context since that's the focus of my research. But, you know, actually part of the strategy of talking about climate change as a health issue has historically we found a lot of evidence that it actually resonates across political viewpoints. And that's part of why we advocate for it as an effective way to talk about climate change, because as James talked about, one of the common values that we share is an interest in protecting health, right? And so I think that's really one of the ways to do it. The other is to find effective messengers, right? So that's also part of our interest in talking about the health effects of climate change. Is health professionals tend to be one of the most trusted sources, even more so than climate scientists in some cases. And so that's really an opportunity there. And in some cases, if a health professional isn't the right source, finding other speakers who can speak to the issue in terms of, say, for instance, a religious standpoint, or even a member from one's own political party who just happens to have views that are counter to the dominant view within that political group can also be effective.
Yeah, thanks, John. So our hour is up. I think this was a wonderful panel, and thanks to all the panelists and also to all of the people who attended.
Thank you, Rob. Thank you, everyone.
Goodbye.
Thank you all.
Enjoy the rest
Take care.